Hello everyone, Medic Level Up here. Today we're going to be talking about a class of medication that is growing very popular in the field of oncology. I'm talking about immune checkpoint inhibitors. Rarely, these medications can cause immune-related adverse events. The easiest way to remember these are the itises. So you've got pneumonitis, hepatitis, dermatitis, colitis, and then you can also have endocrinopathies with these cases. Let's talk about the most common one, which is pneumonitis. The common terminology criteria for adverse events shows you a table to grade the severity of the illness, which I've put up here. When it comes to the clinical presentation of these conditions, it is very difficult to distinguish this from a typical pneumonia. So on history taking, you can have dyspnea, shortness of breath on exertion, and chest pain. On your physical exam, you can have crackles when you auscultate the lung fields, and you can have hypoxia. Diagnostic evaluation will include your X-ray imaging and CT scanning. There are different patterns of pneumonitis that you can see on CT scanning, which I will not discuss here. When it comes to treatment of these conditions, grade 1 severity will mostly be patients who don't have a lot of symptoms, and it is going to be an incidental finding. You will typically hold the immune checkpoint inhibitors in these cases and get a pulmonology consult and have an oncology consult as well. Grade 2 illness will be when patients are more symptomatic and they definitely need some kind of treatment. So you will definitely hold the immune checkpoint inhibitors. You will consider prednisolone 0.5 to 1 milligram per kilogram per day, and then you will see whether the treatment is responsive. If the treatment is responsive, try considering reducing the dose of prednisolone over the next 5 to 7 days and taper it down over the next 4 to 8 weeks. You have to get a pulmonology consult in these patients and concomitantly look for a pneumonia to treat as well. Grade 3 and grade 4 pneumonitis can be severe and life-threatening. In these cases, you have to ramp up the dose of steroids to 1 to 2 milligram per kilogram per day of prednisolone, or you can use 500 to 1000 milligrams per day of methylprednisolone. If the treatment is responsive, you can decrease the steroids and gradually taper it down over the next 4 to 8 weeks. Naturally, you have to be more aggressive in treating pneumonia while covering pneumocystis and pseudomonas at the same time. Get sputum cultures, get bronchoalveolar lavage, and get nasal swabs for these patients to target a specific organism. You have to get a pulmonology and an oncology consult for these patients. If the patient does not respond to steroids, your next step is to consider immunosuppressive therapy in the form of either tocilizumab, IVIG, cyclophosphamide, azathioprine. Thank you so much for watching.